Welcome to Outbreak Brief, the podcast that takes you inside the world's most dangerous infections.
Thank you.
Today, we are tracking a microscopic hitchhiker that currently lives on about 1 in 3 humans. It's basically hiding in plain sight, just waiting for the absolute perfect moment to strike.
Yeah, it really is a master of disguise. I mean, we are talking about a pathogen that's been locked in an evolutionary arms race with human medicine for, well, nearly a century. We're fighting a war against an enemy that lives right on our own skin.
Right. And to start this deep dive, I want you to just picture this scenario. You're going about your week, and you notice a red, swollen bump on your leg.
Just a tiny bump.
Exactly. But it's painful. It's unusually warm to the touch, maybe starting to fill with pus. And you probably just brush it off. You tell yourself, oh, it's just a spider bite, nothing to worry about.
Right, but you never actually saw a spider.
You just assumed.
Exactly, you assumed. And that assumption is exactly what this pathogen relies on. Because that, quote-unquote, spider bite is actually the calling card of a highly deceptive, incredibly aggressive bacteria.
And the stakes with this deceptive little bump are unimaginably high. Because worldwide, this specific bacteria is the leading cause of death due to bacterial bloodstream infections. It carries a terrifying 30% mortality rate.
30%, yeah. It's staggering when you really think about it.
But wait, I have to challenge this premise right out of the gate.
Yeah.
If 30% of humanity is walking around with this bacteria living harmlessly on them right now,
Which they are, yeah.
then isn't our immune system already perfectly capable of managing it? Like, how does a common bug turn into a leading global killer?
So that paradox is what makes Staphylococcus aureus so formidable. Most of the time, our immune system does keep it in check. I mean, under a microscope, this gram-positive bacteria looks almost charming, honestly. Yeah, if you use a gram stain, it shows up as this tiny purple cluster of grapes. It's non-motile, meaning it doesn't, swim around, and it operates on a genome of about 2.8 million base pairs.
Okay, let's unpack this. Because 2.8 million base pairs, that's a massive biological instruction manual for something so tiny.
It is a lot of data, yeah.
But the really unsettling part of our deep dive today isn't its genetic size. It's the real estate it occupies, right?
Absolutely. 20 to 30% of the human population are persistent carriers. It colonizes the damp, dark places on our bodies.
Like where, specifically?
Our noses, our throats, armpits, the groin area.
Wow. So it's like a burglar who doesn't need to break into your house because they already live in your guest room?
That is a perfect way to put it. And most of the time, that burglar is perfectly well behaved. The majority of that 2.8 million base pair genome is dedicated to just basic housekeeping.
Just standard survival stuff.
Right. Just the genetics required to survive, metabolize, and cling to human skin cells. The catastrophic shift happens when we encounter a specific variant, and that's MRSA, or methicillin-resistant Staphylococcus aureus.
The famous MRSA.
Exactly, because MRSA has acquired mobile genetic elements.
Oh, I've read about these. They act like genetic expansion packs, right?
They do, yeah. The most famous one is called the SCC-MEC chromosome cassette. Bacteria can actually swap genetic material with each other, almost like they're trading cards.
That's terrifying.
It really is. So when a standard harmless staph bacteria acquires this SCC-MEC cassette, it gains accessory genes that grant it absolute superpowers.
What kind of superpowers are we talking about here?
Well, these genes provide the blueprints to aggressively invade deep tissues, produce devastating toxins, and, crucially, display extreme resistance to our best antibiotics.
Which brings up a massive historical question for me. How did a common skin bacteria, something that has likely coexisted with humans for millennia, suddenly acquire the blueprints to become a super-resistant killer?
Well, the short answer is we forced its hand.
We did.
Yeah. The history of our battle with this pathogen is basically a textbook evolutionary arms race. So in the mid-20th century, humanity deployed penicillin.
Right, the miracle drug.
It was an absolute miracle drug. It wiped out bacterial infections effortlessly, but S. aureus adapted. It utilized plasmids, which are these tiny rings of DNA, to develop resistance. It learned to manufacture an enzyme called penicillinase.
Wait, and we're not just talking about the bacteria putting up a shield here. How does penicillinase actually defeat the antibiotic?
So it acts like a pair of molecular scissors. Penicillin kills bacteria using a very fragile chemical structure called a beta-lactam ring.
Okay.
When the antibiotic approaches, the bacteria secretes penicillinase, which physically snips that beta-lactam ring open.
Oh, wow.
Yeah, it turns the deadly drug into just useless inert debris. And today, over 80% of staph isolates have these molecular scissors.
That's wild. So we lost the first round, but human science adapts, right?
Yeah.
We went back to the lab and developed penicillinase-resistant beta-lactams and cephalosporins.
We did. We brought out the big guns.
Right. We introduced heavy artillery like methicillin and oxacillin, drugs with chemical structures designed to be bulletproof against those molecular scissors.
And the medical community really thought we had won. We thought, okay, problem solved. Yet shortly after those advanced drugs were deployed into hospitals, MRSA emerged.
Just like that.
Just like that. The bacteria mutated its own penicillin-binding proteins to render those bulletproof drugs completely useless, and the arms race only escalated from there.
Because then we brought out vancomycin, right?
Exactly. When doctors brought out vancomycin, which is the absolute last line of defense drug, MRSA changed the battlefield entirely.
Okay, you have to explain how it beat vancomycin, because the mechanism here is fascinating. Normally, antibiotics work like a key fitting into a very specific lock on the bacteria's cell wall.
Correct. So vancomycin targets a specific structural lock called the terminal peptidoglycan. Specifically, it's a peptide sequence known as D-alidala.
D-alidala. Got it.
Right. Vancomycin binds to this sequence to destroy the cell wall. So in response, MRSA literally changed the shape of its own lock. It mutated that sequence to D-alidala.
Yeah.
So the drug arrives, tries to bind, and simply slides right off.
Every single time we build a higher wall, MRSA builds a taller ladder.
Exactly.
So, since we clearly cannot easily kill this pathogen with drugs, we have to look at how it gets to us in the first place. I mean, if it doesn't have flagella, if it can't swim or fly, how is it spreading so effectively across the entire globe?
Because we do the moving for it. Transmission relies heavily on skin-to-skin contact, or contact with contaminated surfaces, which we call fomites in the medical field.
And its environmental survival skills are chilling, right?
Very. By dialing down its own metabolism, MRSA can survive for hours, days, or even weeks on everyday objects.
Weeks? On what kind of objects?
Oh, damp towels, shared razors, gym equipment, light switches, computer keyboards. All of these can harbor dormant, highly infectious MRSA cells.
But it can't just burrow through healthy, intact skin, can it? It requires some sort of breach.
Yes. It needs a cut, a scrape, a shaving nick, or a surgical wound to cross the perimeter. But once it crosses that perimeter, it immediately initiates a hostile takeover.
What does that look like?
Well, what's fascinating here is that when it enters deep tissue or the bloodstream, it creates microthrombi.
Which are tiny blood clots.
Exactly, tiny blood clots. The bacteria actively secretes an enzyme called coagulase. This enzyme hijacks the human body's natural blood clotting proteins. It forces fibrin to weave a protective web directly around the invading bacteria.
Wait, so it essentially builds a fortress out of our own blood so it can hide inside.
It does. It walls itself off from our white blood cells right at the gate.
That is diabolical. Given that it survives for weeks on light switches and hides inside our own blood clots, who is actually in the crosshairs here, the sources point heavily to healthcare settings.
Yeah, hospitals are ground zero because they concentrate vulnerable populations.
Makes sense.
Healthcare workers, hospitalized patients, individuals with artificial joints or pacemakers. Also, people who inject drugs face severe risks. These are environments where vulnerable people have frequent breaks in their skin, intravenous lines acting as highways right into the blood, and a high prevalence of the bacteria just sitting on surfaces.
But the sources also highlight a major risk outside of hospitals. And here's where it gets really interesting, the sports connection.
Oh, absolutely.
Because when you hear about MRSA in sports, you immediately think of football and wrestling. Sweaty guys grappling on mats with open cuts. But it is spreading aggressively in soccer, rowing, fencing, and basketball. Why fencing and rowing?
Well, it comes down to the microscopic breaches in the skin and shared equipment. In those sports, you have shared locker rooms, unwashed uniforms sitting in warm gym bags, and friction.
Friction.
Yeah. Sliding on artificial grass in soccer creates turf burns. Now, these aren't deep cuts, but they are massive fields of microabrasions that strip away the skin's armor. It offers MRSA thousands of tiny doors into the body. Furthermore, if we connect this to the broader picture, colonization itself is a massive liability.
Right, the burglar we talked about earlier.
Exactly. If you are one of the 30% of people naturally carrying S. aureus in your nose, you might accidentally wipe your nose and then touch a turf burn on your leg.
Oh, no.
Any physical trauma or surgical incision can suddenly turn your own microbiome against you. You literally become the source of your own severe infection.
Let's walk through the lived experience of that infection.
Yeah.
We started the deep dive with the superficial skin symptoms, the whole specter bite illusion. You get painful sores, red and swollen carbuncles, heat radiating from the skin, and pus.
Right, that's the local infection.
But what happens if it breaches the local tissue, escapes that blood clot fortress, and enters the systemic circulation?
That progression leads to bacteremia, which is a severe bloodstream infection. Once MRSA is navigating the bloodstream, it can seed itself in any major organ, the heart, the lungs, the bones, and then it begins releasing a devastating barrage of toxins.
And these toxins are highly specialized. Let's talk about the PVL toxin, because this isn't just a generic poison.
Not at all. The pantin-valentine leukocidin, or PVL toxin, is a weapon designed for cellular destruction. It causes necrotizing pneumonia by specifically targeting human white blood cells.
So it attacks the very cells trying to fight it.
Yes, it binds to the membrane of the immune cells, forms a pore, and literally pokes holes in our immune cells until they leak and die, all while simultaneously destroying lung tissue.
That is horrific. Then there is staphylococcal scalded skin syndrome, which primarily affects children, right?
Yes, SSS. In that case, the bacteria releases exfoliative toxins that act like chemical solvents. They dissolve the cellular glue holding the epidermal layers together.
Causing the skin to peel.
Exactly. The top layers of the child's skin will blister and violently peel off. It's incredibly painful and dangerous.
And we also see toxic shock syndrome, driven by superantigens.
Right. So normally, when the immune system detects a threat, it activates a very specific targeted number of T cells.
Like a measured response.
Exactly. But superantigens short-circuit this system. They force the immune system to activate a massive indiscriminate pool of T cells all at once.
Which triggers a cytokine storm.
Yes, an overwhelming chaotic immune response that damages the host's own tissues. It leads to a catastrophic drop in blood pressure and multi-organ failure.
Okay, so for the listener who is right now suddenly hyper-aware of every single itch and bump on their skin, when does a red bump require immediate medical panic?
You need to look for systemic red flags, specifically fever and a lack of progression.
Okay, fever.
If you have a suspected skin infection accompanied by a fever, or if the localized redness, swelling, and pain show absolutely no improvement after 48 hours, you need evaluation by a healthcare provider immediately.
And people shouldn't try to pop it.
Under no circumstances should you pick at it or try to pop it. That can push the bacteria deeper into the tissue. Just cover it with a clean bandage and seek medical care.
Because if you wait until you are battling a bloodstream infection in the ICU, the doctors have to figure out how to deploy drugs against a pathogen that resists almost everything.
Right. And the first step in that clinical evaluation is determining the scope of the threat. Is the infection uncomplicated or complicated?
What's the difference?
An uncomplicated infection means the source is controlled, like a superficial abscess that has been fully drained. There are no artificial implants involved. The patient's fever breaks within 72 hours of starting antibiotics, and blood cultures clear out quickly.
But the grim reality in emergency rooms is that most bacteremia cases are classified as complicated, aren't they?
Unfortunately, yes. And in complicated cases, the medical arsenal is limited and highly toxic.
What do they use?
Well, if laboratory tests confirm it is MSSA, which is the methicillin-sensitive, non-resistant version, doctors rely on an antibiotic called cefazolin.
But if it's MRSA?
If the lab confirms MRSA, they're forced to use heavy-duty intravenous drugs, things like vancomycin, daptomycin, ceftaroline, or ceftobiprole.
But wait, if we have these incredibly powerful last resort drugs like daptomycin, why are patients still dying? I mean, the drugs only work if they can actually touch the bacteria. Earlier, we talked about MRSA building blood clot fortresses. Does it do something similar on medical implants?
It does, and it is known as the biofilm problem. MRSA is notorious for attaching itself to heart valves, artificial knees, and pacemakers, and then constructing a biofilm.
I used to think of biofilms like throwing water balloons at a concrete bunker, but that doesn't really capture the mechanics, does it? It's more like the bacteria pour quick, dry cement over themselves.
Yeah, it is a much more accurate visualization, yeah. The bacteria secrete an extracellular polymeric matrix.
A matrix.
It's a thick, sticky slime made of sugars, proteins, and DNA, and it cures into a dense biological cement. So when doctors pump a patient full of daptomycin, the antibiotic molecules get trapped in the outer layers of that cement. They get stuck before they can ever reach the dormant bacteria hiding in the center.
So the drugs are effectively useless.
Pretty much.
Yeah.
Because the antibiotics cannot penetrate the biofilm, surgeons are frequently forced to open the patient back up and physically scrape out the infected tissue.
Oh, wow.
Or completely extract and replace the artificial hip or pacemaker just to clear the infection.
That is the brutal reality for a patient.
Mm.
So if the drugs can't reach it and the bacteria mutates to resist the drugs anyway, why can't we develop a vaccine? We have vaccines for polio, measles, COVID. Why is there no vaccine for MRSA?
Well, developing a vaccine relies on training our immune cells, our macrophages, to recognize and consume a pathogen. MRSA's immune evasion toolkit is designed specifically to prevent recognition. First, it utilizes a cloaking device.
A cloaking device.
It surrounds itself with a slippery polysaccharide capsule, so our immune cells simply cannot get a grip on it to consume it.
It's like a highly trained spy infiltrating a secure facility. It doesn't just sneak in, it actively disables the security cameras.
Exactly. It secretes proteases, which are enzymes that chop up our antibody markers, totally disabling the molecular alarms our bodies set off.
Incredible.
And when our first responder immune cells, the neutrophils, do manage to corner the bacteria, they attempt to destroy it using an oxidative burst.
What is that?
They essentially spray the bacteria with highly toxic oxygen molecules, very similar to bleach. But MRSA anticipates this. It produces an enzyme called catalase that neutralizes those toxic oxygen species instantly.
It literally defuses the oxygen bomb as it's going off.
It does. Furthermore, it alters its own surface electrical charge.
Wait, really?
Yeah. Our skin naturally produces antimicrobial peptides that carry a positive charge. By shifting its own surface to a more positive charge, MRSA acts like two opposing magnets. It actively repels our body's natural defenses before they even make contact.
Okay, so it wears a slippery disguise, it diffuses our immune bombs, and it magnetically repels our natural defenses. It is no wonder a vaccine has eluded us.
It's incredibly frustrating for researchers.
So with no vaccine coming to save us tomorrow, and a drug supply that is constantly being outsmarted, our best defense is preventing the breach in the first place.
Prevention is our most powerful tool, absolutely. On an individual level, aggressive, consistent hygiene is non-negotiable. Washing hands thoroughly with soap and water, and keeping all cuts and scrapes covered with a clean, dry bandage until they are completely healed.
And we shouldn't be sharing towels, right?
Never share personal items like razors or towels. And crucially, you must dry your clothes and gym towels fully in a machine dryer. Air drying is insufficient. The high heat of a machine dryer is required to kill dormant bacteria.
On a facility level, I know the CDC enforces strict protocols for gyms and athletic centers. Shared equipment has to be wiped down constantly. And I was reading that the specific bleach dilution matters. It's a quarter cup of standard household bleach to 1 gallon of water. Why that exact ratio?
Because that specific dilution hits the chemical sweet spot.
How so?
Well, it is concentrated enough to break down the bacterial cell wall and dissolve the structural proteins, but dilute enough that it doesn't evaporate too quickly. It allows the liquid enough contact time on a bench press or a wrestling mat to ensure total destruction of the pathogen.
You know, I remember a few years ago, a local high school completely shut down for 3 days because one wrestler got a MRSA infection. They brought in these professional cleaning crews in full hazmat suits.
Yeah.
Is that level of panic warranted?
No, public health guidelines indicate that schools generally do not need to close to disinfect for a single MRSA case.
Really?
Yeah. Routine, thorough cleaning with the proper disinfectants is entirely sufficient. The focus should remain on proper hand hygiene and covering wounds, not theatrical hazmat panic.
That makes a lot of sense. What about the people who are naturally colonized? The burglar in the guest room. If someone keeps getting recurrent infections, can we just evict the bacteria?
We can attempt a process called decolonization for high-risk patients or households experiencing cyclical infections.
What does that involve?
It involves an aggressive, multi-pronged chemical assault. You apply a topical antibiotic called mupirocin ointment deep inside the nasal passages, wash the entire body with chlorhexidine surgical soap, and take heavily diluted bleach baths to try and scrub the bacteria from the skin entirely.
But despite knowing exactly how to decolonize a household and how to wipe down a gym, MRSA remains an endemic threat. The numbers are staggering. In the United States alone, the CDC estimates there are over 70,000 severe infections and 9,000 deaths annually.
And the human cost is devastating, and the economic toll is crippling.
I can imagine.
We are looking at billions of dollars burdened onto the global healthcare system every year. Treating a complicated MRSA infection involves prolonged, multi-week courses of intravenous antibiotics, heavily extended hospital stays, and those invasive surgical interventions required to scrape out biofilms.
Which brings us to the future. Are we destined to keep losing ground in this evolutionary arms race? Or is human science finally catching up?
The battlefield is actually shifting rapidly right now because of diagnostic innovation. One of the biggest game changers currently being deployed is MALDI-TOF mass spectrometry.
MALDI-TOF. How does that actually change the experience for a patient lying in an ICU bed?
It buys them time. Historically, doctors had to draw blood, put it in a petri dish, and wait days for a culture to grow just to figure out if the infection was regular staph or MRSA.
And days are critical in the ICU.
Exactly. But MALDI-TOF uses lasers to vaporize a sample of the bacteria. It measures the exact time it takes for the bacterial proteins to fly through a vacuum tube.
So it generates a unique fingerprint of the pathogen based on its molecular weight.
Precisely. Using this technology, a hospital lab can identify the specific resistance profile of the bacteria straight from the blood cultures in a matter of hours. Doctors can switch from broad, guessing game antibiotics to the exact right, targeted drug almost immediately, which saves countless lives.
We are also seeing new therapies emerge on the pharmaceutical side, aren't we?
We are. We're witnessing a promising shift toward long-acting lipoglycopeptides, such as a drug called dalbavancin.
How is that different from the old IVs?
Instead of a patient being tethered to a daily IV drip in a hospital bed for a month, these new drugs have such a long half-life in the human body that they can be administered with a single once-weekly dose.
That is a massive quality of life improvement.
Huge. Furthermore, massive clinical studies are proving that switching early from IV antibiotics to highly targeted oral pills can be entirely safe for low-risk patients. It gets them out of the hospital and away from other hospital-acquired infections much sooner.
So what does this all mean for us? We started this deep dive analyzing a relentless, terrifying killer masquerading as a common bug bite.
A very successful killer, yeah.
A pathogen that steals genetic secrets, builds concrete fortresses out of our blood, and literally diffuses our immune system's bombs. But as we look at how seamlessly it integrates into 30% of the human population, maybe our entire approach has been slightly skewed.
How do you mean?
Well, since we can never truly eradicate a bacteria that naturally colonizes a third of the human race, the future of medicine might not be about inventing stronger and stronger bombs to kill MRSA.
Ah, right. That requires a profound shift in clinical perspective.
Instead of total scorched earth war, maybe the future of infectious disease is about learning how to peacefully negotiate with the microscopic ecosystem already living on our own skin, managing the delicate balance of our microbiome rather than trying to chemically pave over it.
It is an ecosystem we carry with us from the moment we are born. Understanding its rules rather than just trying to break them is ultimately our best defense.
Stay informed, stay prepared. This has been Outbreak Brief.